Okay, today we're going to discuss procedures for spondylolisthesis. Great similarity to your standard Protocol 1 and Protocol 2. There's just a few variations that you need to take into account. Number one is we distract over a fulcrum. So we want to create a fulcrum that can either be done through the use of a cushion, as we see over here, or if your table is equipped like this one, we can actually raise this thoracic and lumbar section. If you'll grasp it here, there's a release just behind the tension knob of the thoracic section, and you can bring this up, and that will create a fulcrum. The apex of the fulcrum needs to go directly under the anteriorly displaced spondylitic segment. Okay, so if it's an L5 true lytic spondylolisthesis, you want to get the body of L5 right over there, and that's done to stabilize or support that unstable anteriorly displaced segment, just to make sure that we don't displace it potentially any further. The fulcrum also serves to reduce the lumbar lordosis. In spondylolisthesis, there tends to be an accentuation of the lumbar lordosis, and very difficult to get a contact with an accentuated lordosis. So you want to try and remove the lordosis. Again, that is the purpose of the fulcrum. The other thing to consider is we never distract the lytic segment. We always go to the next segment directly above. So if we have an L5 spondylolisthesis, we will contact the L4 spinous process. If it's an L4 spondylolisthesis, we'll contact the L3 spinous process. So keep those things in mind. Otherwise, we follow the standard Protocol 1 or Protocol 2 guidelines. Protocol 1, if they have a spondylolisthesis with a radicular component, then we follow Protocol 1. If they have a spondylolisthesis with no lower extremity, no radicular component, we follow Protocol 2. Okay, so Shannon, come on around and let's go face down. Raise her up. Expose the area to work on. All right, so we'll just say she has an L5 spondylo. So there's L4, and then there's L5. So we want L5 actually on the apex of this fulcrum. So let's come down a little this way. Good. Okay. So again, there's L4, and so L5 is now being directly supported by the apex of this fulcrum right here. And then you can also see that the lordosis has been reduced. You can see if we drop this, you'll see how the lordosis forms again, and that would be very difficult. That reduces it significantly right there, and that's going to allow us to get a good contact. All right, so if it is an L5 spondylolisthesis, then our contact point is going to be L4. See if we can give you some clues in finding that. With a spondylolisthesis, the lytic segment, okay, in this case, this spinous process which is separated from the anterior column, tends to slip posteriorly. So it feels like a very posterior segment, and then when you get over it, you'll notice that there is like a step off or a valley, and that would be where the L4 spinous process is sitting. So they're fairly easy to find. So again, if she had an L5 spondylo, we would feel L5 would be a very posterior feel, almost like an L5 spinous is trying to come through the skin, and then as we rolled over it onto L4, we would drop down right onto that L4 spinous, and that would be your contact point. Okay. Now, if she had the spondylo and there was a radicular component, then we would do a Protocol 1. Okay. Okay. Oops. Okay. So we want to stabilize a little better than that. I think we've added some air to this table. Yeah. because of the length of my arms, I do not necessarily use the tiller bar. Okay, and so you have that option as well. Okay, so L5 spondylo, right radicular component, contact point is L4. Okay, so we're on L4, and because there's radicular component, we follow our formula for 3/22 decompression sessions. So we would find that area of elastic resistance, and then make sure you're square to the table, square to the patient, arm is locked down, and then you would do your 5 4-second pumps on L4. Basically just following the Protocol 1 guidelines all the way through. Same scenario without a radicular component. Again, L5 spondylo, no radicular component. Make sure you get off of L5 and onto L4 spinous. Find the area of elastic resistance. Do your 10 2-second pumps. Release your lateral flexion lever. Find the area of elastic resistance, and then do your 10 lateral flexions left, 10 lateral flexions right, 10 circumductions left, 10 circumductions right, and then 10 extensions. Okay, so pretty much the protocols are consistent except for these few additions. Again, we adjust over a fulcrum to stabilize that anteriorly displaced segment and also to reduce the lumbar lordosis. And then always remember to go directly, one segment directly above the spondylo. There'd be no reason to distract the spinous of the spondylo itself. There'd be no advantage to it at all. Usually there are fibrous adhesions that are holding what's left of the articular columns and the lamina and the spinous, and this just does not need to be messed with. It's already an unstable segment by its nature, and we don't want to go in and create more instability. So we go directly above. So if we can maybe zoom on this one, if that's possible. You can see over here, this is an L5 spondylo. You can see the defect right over there. There's the defect. And you can see that there's the defect right there. And the doctor is contacting with the Stenar the L4 spinous process. And that's the basic formula for treating a spondylolisthesis. Very, very effective. Works wonderfully well for the lytic type or the non-lytic type. And the non-lytic type would be degenerative spondylolisthesis, where there is no pars defect, but you do have anterior slippage due to advanced degenerative changes in the facets and in the disc. And that's an overview of spondylolisthesis procedures. Today we're going to discuss the scoliotic patient as it applies to the Cox flexion distraction procedures. There's basically 3 applications. One is a scoliotic patient with a disc lesion. 2 is a scoliotic patient without a disc lesion. And 3 is a scoliotic patient that you're actually treating for either stabilization or possibly reduction of the scoliosis. So the first one, we'll just say we'll say this is Shannon's x-rays right there, and that's a standard configuration for an S-shaped thoracolumbar scoliosis. Lumbar spine is deviated laterally to the left. We call that a levoscoliosis. The thoracic spine is laterally deviated to the right, and that's a dextroscoliosis. Okay, so if Shannon came into the office and possibly didn't even know she had a scoliosis, some do, some don't, but her main presentation was severe acute back pain with pain extending down the back of the right leg all the way to the foot. So we'll just say she has a true radicular component. Her main concern is she's in a lot of pain, and she would like you to help her with that and help her get some relief of that condition. Okay, so in examining her, you discover that it is disc related, and you want to use Cox procedure. You x-ray her and notice that she has scoliosis. So the problem that we have here is that her vertebral end plates are not level. Okay, the vertebral end plates are all sitting on angles. And when we distract, we're going to be much more effective if the vertebral end plates are level. But in her case, we've got, they're wedged open on the left side. Okay, so that's easily correctable. So we're gonna give her a scoliosis. Just relax forward. All right, so oops. All right, so let's say that is her normal configuration. And again, that matches the X-ray. Again, we mentioned that we get much more effective distraction if we can level the vertebral end plates. That way we get even distraction going throughout the fibers of that disc, as opposed to uneven distraction, which has the potential to create complications, which we'll discuss in lecture. So what we're going to do to correct this, it's really simple. We're going to release the lateral flexion lever, and we're going to eyeball her lower back, the lumbar musculature, the erector spinae, and we're going to reduce that scoliosis. And it'll get to the point where you see those erector spinae muscles basically just pop into place, and then you're going to lock the lateral flexion lever, okay? And so all we've done is we've taken measures to reduce that scoliosis and level off those vertebral end plates. And then we can go ahead and just use our standard protocol 1 on whichever vertebrae may be involved, whether it's L5 or L4, those are typically the two most common levels. We would just do your standard protocol 1. It's just that the table looks a little misconfigured, but if it was, let's say it was an L4, we would get over the patient just like we would for standard protocol 1, find the barrier of elastic resistance, and do your 5 4-second pumps. You do that 3 times. The only thing that we've done is we've leveled the vertebral end plates. We're going to get a lot more effective distraction to that disc by doing that. So that's the first application for a scoliosis. All right. The second application is when you have an acute lumbar spine disorder, no radicular component. And the fact that there's no radicular component means that she would be placed into protocol 2 for reestablishment of physiologic ranges of movement of the vertebral segments. Okay, so let's say you know, she came in with an acute lumbar spine disorder. We discerned that L4 was the offending vertebrae. There was no radicular component, so we wanted to go in and recondition or mobilize L4 using Cox Protocol 2. We basically release the flexion lever. It's already released. Release the lateral flexion lever and get a contact on L4 and do your 10 2-second pumps in flexion. Okay, all right. Now is lateral flexion, and the problem that we run into is we really don't want to laterally flex this patient into the concavity of their curve, for the, you know, with the potential of an increase in the curvature. Okay, so for someone with a scoliotic configuration with protocol 2, we only distract into the convexity of the curve, not into the concavity of the curve. So when we get to lateral flexion, you find that barrier of elastic resistance, and you only laterally flex to the left. Same thing for circumduction. You know, standard protocol 2 is we do circumduction to the left and to the right, but with a scoliotic curve, we would not want to take her to the right because that has the potential of increasing that curvature. So when we get to circumduction, we're only going to circumduct to the left in this particular case. Okay? And then extension would be standard, normal protocol 2, where you change your line of drive to 2/3 P to A and 1/3 I to S. So the thing to consider and apply in a case like this, again, this is a lumbar spine disorder without a radicular component where we're going to do protocol 2, is that we eliminate 2 of the movements. And those 2 would be lateral flexion into the concavity and circumduction into the concavity. And otherwise, you just use standard protocol 2 procedure. Okay. The third one is for an actual scoliosis, where you might have an adolescent who comes in, maybe they were screened at school, and you know, the mom brings the child in and says the nurse believes the child has a scoliosis. and we wanted you to take a look at it. And you examine the child, you find that there looks like there is evidence of scoliosis. You take an x-ray, and that's the child's x-ray right there. So we want to see if we can do something to stabilize it, keep it from it progressing, maybe even reverse it. So in a case like this, we're going to do protocol 2, but we're going to do it more on a global basis. We're not just going to pick a particular segment. We're actually going to distract, in this case, L5 all the way to T11. And we're also going to follow that same principle that we just discussed. We're not going to do lateral flexion or circumduction into the concavity. So in this particular case, I'll tell you what I'm going to do. I'm going to, for learning purposes, I'm going to reverse your scoliosis. The camera's this way. Okay. Okay, so I like to stay on the convexity of the curve, because that way I can put a little counter pressure into it. Okay, so in this particular case, we would start at L5. We would do 10 flexions at L5. We'd go to L4. We'd do 10 flexions. L3, L2, L1, T12, T11. Right? We want to get the whole span of that scoliosis. All right, we're now ready for lateral flexion. And so what we're going to do is we're going to start at L5. We're going to find that area of elastic resistance, and we're going to do 10 lateral flexions to the right. Move up to L4, 10 lateral flexions to the right. Move up to L3, 10 lateral flexions. L2, L1, T12, T11. We're not going to do lateral flexions to the other side. So in other words, we're only going to do half of the lateral flexions, making sure that we do not go into the concavity of the curve. All right, circumductions. We're going to drop back down. We're going to do, start at L5. We're going to do 5 circumductions to the right at L5. 10 circumductions to the right at L5. 10 circumductions to the right at L4. 10 circumductions to the right at L3, L2, L1, so on and so forth. We're then going to move back down and do our extensions. Start at L5. We're going to do 10 extensions, L4, 10 extensions, L3, 10 extensions, so on and so forth. So when your goal is to see if you can stabilize or reduce a scoliotic curve, you're going to follow the protocol 2 guidelines, but you're going to do it more in a global fashion, and you're going to eliminate lateral flexion and circumduction into the direction of the concavity. And this can be an effective way, again, at either stabilizing or potentially reducing the scoliotic curve. And that's an overview of scoliosis.